Hello. Thank you for attending this final session of the final day of the APAO meetings in Delhi. I warmly welcome all of you here, and we are about to begin. So I kindly ask everybody to take their seat, take your seat, and so unfortunately, some of the presenter, um, this is the end of the day of the session, so we'll attend here. And but we have lots of time to discuss, and so since our few scheduled speaker could not attend, we're gonna have a Q&A after each presentation. Uh, Please feel free to raise your hand, come to the microphone, and so each speaker finish their talk. And so let me start with our first speaker. The presentation name is Epidemiology, Occupational and Non-Occupational Eye Injury. So Salman Hamid, yeah, please.
Thank you. Respected panelists, dear audience, Assalamu alaikum wa rahmatullahi wa barakatuh. I am Dr. Salman Ahmad Tahir, MS Residence in Bangladesh Medical University. So the topic here is epidemiology of occupational and non-occupational eye injuries in cases treated in 4 eye hospitals in Bangladesh. There is no financial disclosure in this presentation. So eye injury is damage to the eye which is regarded as the second leading cause of vision loss globally, usually after cataract. This was in a research published in 2017. There is many factors that contribute to eye injury which can occurs anywhere, anytime to any person regarding to its socio-economical impact. So the eye injury usually result from physical trauma, exposure to hazardous substance leading to temporary or permanent vision loss. Both occupational and non-occupational eye injury contribute significantly to the global burden of the ocular trauma. This is some research. In USA alone, 2.5 million of ocular injury usually occurs annually at home, and on that only the cost is more than 300 million US dollar. In Bangladesh alone, 40.1 of eye injuries usually occur in domestic settings, and while occupational eye injury prevalence ranging from 88 to 1,920 cases per 100,000 individuals in developing country. In Bangladesh, the workers in manufacturing, construction, agriculture and textiles are at a high risk due to inadequate safety measures. The research gap here is there is limited data on the epidemiology of eye injuries in Bangladesh, particularly in both occupational and non-occupational settings. So the aim of this study to analyze the epidemiological pattern of eye injury, to identify the risk factor and causes, and provide evidence for targeted prevention strategies and improvement of the health services. The methodology is a descriptive cross-sectional study which was conducted among purposely selected 117 eye injured patients in a 4 eye hospital in different districts, which was conducted from the 1st of March 2022 to 20th of May. The data was analyzed by ASPSS for window version 24.0. So the socio-demographical profile here is gender. First is male was 69.2%, while remaining is female. The lower income people was the highest affected, 62.4%, and remaining is a lower middle income. Based on the religious, the large of the convenient was 92.3%, and the remaining is 7.7% is Hindu religions. The marital status of this program was 68.4% married, and remaining 31.6% were unmarried. So the socio-demographical profile of the participant, the age group was from 19 years to 30 years was the highest affected, 43.6%, and most of them was male, 69.2%. The profile of the participant socio-demographically, most were Muslim, and the educational qualification was during secondary schools, and lower income people were the highest affected. The causes of eye injuries at workplaces was mainly due to lack of protective measure, remaining was carelessness. The causes of eye injury at home due to carelessness came top. The second one is human contact, while assault, fall, tiredness remain there as well. The causes of eye injuries at other areas was contact with inmate matters. Fell on the ground, carelessness, assault still there. The activities at workplace during eye injury, maintaining or cleaning of the instrument was on top with a frequency of 12, around 10.1%. The activities at home during eye injury was looking after child on the top, doing household chores came second, and exposure to household materials still there was 13.7%. Other places during eye injuries, riding on a vehicle is on top. The activities of other places during eye injury, the place most of the injury of 53.8% were at home, and at the time of the injury usually in the morning, and most of the injuries was closed injuries, 81.2%, remaining was open globe injury. So the people of the 19 to 30 years of old were found to have the highest number of cases, as at this age group people usually become more active, more outgoing, and even female or male, they get married, they sustain eye injury while doing housework, cooking. The people with no or less than higher secondary education were the majority of cases exposed to eye injury, having lower awareness about the eye health and safety, leading to increase the injury risk and the consequence as they take less or no protective measure. So the conclusion, the study was the first ever study focused on both occupational and non-occupational eye injuries in Bangladesh. It was a comprehensive study covering a large geographical area of Bangladesh, which can remain as a baseline study to compare the finding from features similar type of research. Eye injury is a common event at home, workplace, and other area irrespective to epidemiological distribution. Educational and awareness program among people of lower socioeconomic status, particularly the younger males, should be targeted by the government, Ministry of Health, Ophthalmological Society, eye hospital, and NGOs with the interest in eye health. School teacher and religious leader can be trained to provide mass awareness about the seriousness of the health and the consequence of the injury among school children and general community members. These are my references. So let's commit to making eye safety a priority in all aspects of our lives. Thank you for your patience hearing.
Thank you for your wonderful talk, Salman Hamid. So, if there is any questions from the floor, please come to the microphone and raise your hand, or so ask freely. And so, I have one more question. So, you already mentioned that the prevention is important, and education and awareness is the most important factor. So, what else can we do for protecting them from the eye injury?
Well, it can be covered from a different level. Like from as an ophthalmologist, we should cover the awareness to every patient that come to us, especially depending on their socioeconomic status first, and then the second one depending on their occupation. So we can give them a measure to wear the protective measure for the workers and for other people, while the people who are working at home, they should be educated about the chemicals, because most of the injury that came to us was a chemical injury during household chore. So protection about its use, keeping it away from the children. This way we can protect both at home and both at different setting. And as domestic setting was there also prevalence issues, we should address it as a large issue and conduct further research on it, give more education to the people about these issues overall.
I think your recommendation it was a very good presentation.
Thank
and you have documented it nicely. And it's surprising that household injuries have scored more.
Yes.
Otherwise, in rest of the data, household injuries they come
still
second,
backward,
third, or
yes.
back
I
in the
agree.
list. And field and sports related injuries and field work injuries and occupational injuries were more common in the various studies which have been done. But one thing, have you documented the type of injury and
Yes, most, like I have mentioned here, around 82.1 was closed injury.
close?
Just like I told you, fall or trauma, whatever it is, but very less was open injury. It was mentioned there. As around 18 point something was an open globe injury, while remaining was closed.
Okay, so visual outcome status.
Yes, it was mentioned. The visual outcome usually following globe injury was good. Actually, there was not much of a defect, while the open injury following assault and other have very bad visual outcome.
So prevention for this thing, what I suggest is that we should ask the government to inform the chemical or the soap and all that should be mentioned on
That should be
the
labeled, yes,
yeah,
exactly. It should
it's
be
clearly
labeled.
labeled on in a bright color, and
Yes,
that
color coding
that
should
should
be
be
used as well. Yes, yes,
yeah,
I agree
for
to
the
that point.
prevention. That is very, very important.
I
That
agree.
is what we are
Oh,
recommending
yes.
in India
India, I
to the
see.
government, to the government
Still learning.
agencies.
Thank you.
Thank you. Thank you.
Thank you so much. Have a
Yeah.
good day.
So,
Next.
yeah, if there is any comment or question of the first author, so we're gonna move to the next speaker. The next speaker is Samir Moha uh, Patra. So, okay, the presentation is functioning of an orbital maxillofacial reconstruction unit in a specialized tertiary eye center. So, please. Next speaker here. So,
Good morning, everyone.
wanna
So I will be
introduce them?
presenting
So,
research conducted at our institute on the orbitomysia
yeah, he's not
maxillofacial
here.
trauma
He's
reconstruction,
here.
and it's because and the impact of orbitomyxillofacial reconstruction unit in a tertiary standalone eye care center in our country. And I have no financial disclosures. So midface of the face is considered to be a crumple zone because any trauma to the midface causes multiple fractures and often lead to side-threatening ocular injuries. The incidence of blindness ranges from 0.3 to 9%. Management of such cases pose a challenge because there are concomitant surgical repair of both maxillofacial, ocular and orbital injuries are required in a very coordinated manner, and most of these cases they present late. And the maxillo-orbital reconstruction unit, or what we call as the OMF unit, basically consists of an integrated team of ophthalmologists, maxillofacial surgeons, neurosurgeons with a dedicated trauma or and a fast-track trauma corridor. And this is what we have prepared, or we have in our existing setup at our institute. And the aim was to report the impact of this unit at our own center in the management of patients with orbital trauma. The outcome measures, the primary outcome measures was to look into the improvement in cosmesis, that is restoration of facial symmetry, and the visual status improvement or stabilization on the injured eye. It was a retrospective interventional study conducted at the L.V. Prasad Eye Institute, Bhubaneswar from August 2016 to December 2024. And it included all patients with orbitomyxillofacial trauma who underwent a reconstruction and had at least a follow-up period of 3 months. We have excluded all patients who had got a follow-up period of less than 3 months and having any congenital deformity like craniostenosis were excluded from the study. So after an IRB approval was obtained, any patient that comes with trauma, a comprehensive examination was done, followed by appropriate imaging. Then the injuries were classified as simple or complex fractures depending on the severity, and triaging was done, and any patient who has a side-threatening complication, either intravenous methylprednisolone or other ocular surgeries which required an open management of open globe injuries were done, followed by an orbital reconstruction, and the patient was sequentially followed up for about at least a period of 3 months, and the outcomes were recorded, and any complication that happened in the immediate post-operative, intraoperative, or late post-operative were analyzed. And overall, after fulfilling all these criteria, we had a data of 37 patients, which the data was analyzed, out of which the males were predominant in our cohort of patients, and the right eye was most commonly affected than the left eye. Road traffic accident followed by workplace trauma was the most common mode of injury, and in one of our cases, animal bite, particular dog bite, was found. The mean age of presentation was 29.2 to 9.7 years, with a range from 6 to 53 years. The 6-year child, which I mentioned here, was a case of dog bite in our cohort. So we classified simple versus complex orbital fractures depending on this paper published by Dr. Gangadhar, and we considered simple injuries as having any floor fracture with or without medial wall or the rim involvement, and complex fractures were involvement of 2 or more walls along with lateral wall or the NOE complex fractures. So in our cohort of series, 32% of patients were having simple injuries, whereas 68% of patients were having a complex kind of orbital injury. Now, you can see that the patients with less than 40 years of age has the maximum representation, and complex fractures were found in 68% of the patients. And in about 54% of patients, we had associated ocular injuries, out of which 80% of these ocular injuries were associated with complex fractures as expected. Now, the median time of presentation from trauma was 3 weeks for the range from 5 days to 40 weeks. The median time to intervention was 8 weeks for the range from 2 weeks to 2 years. So reconstruction more than 6 weeks were done in 59% of the patients. And in adjunctive procedures like a bone, nasal bridge reconstruction or fat grafting or skin grafting was done in about 41% of the patients. The most common implant that we use in our patients were bone grafts in 73% of patients, followed by titanium mini plates and messes in about 65% of patients. You can see here the most common presentation was decreased vision, followed by inophthalmos, followed by diplopia. And you can see that the timing of reconstruction, if you consider this, the simple fractures were actually repaired early in the period of surgery, followed by the complex fractures. The most common time period was a delayed reconstruction because of existing multiple injuries that the patient do have in road traffic accident patients. So the visual acuity at presentation and the final best corrected visual acuity was comparable in both the fracture groups, and there was no difference in the best corrected visual acuity between early versus late presentation, and the ocular injuries were associated with poor visual outcome as expected, and it was statistically significant. So in our cohort of patients, 8 patients were monocularly blind at presentation, and that did not show any improvement at the final follow-up. So this is the criteria that we followed in grading our cosmetic outcome of the patients, in which the excellent and good outcome were clubbed together as favorable outcome, whether fair to poor and very severe facial asymmetry was considered as unfavorable outcome. So this is how the results shown. This is what we consider as favorable outcome, which was found in about 78% of our patients, which included excellent and good outcome as per the criteria mentioned in the table. Whereas unfavorable outcomes was seen in about 22% of patients. So this is how, this is what exactly a favorable outcome means. Near restoration of facial asymmetry, whereas this is how an unfavorable outcome looked like, where in spite of multiple attempts, we could not improve the facial asymmetry of the patient. Now, 78% of the patient had a favorable outcome, that is excellent or good facial symmetry in our cohort of patient, and interestingly, complex fractures had a better outcome than simple fractures, and it was statistically significant. Now, we had a couple of complications in this entire cohort of 37 patients. In 5 patients, we had different types of complications, like an implant extrusion, a seroma formation at the site of bone donor site or bone graft harvesting. We had a few patients, we had developed saldo and an abscess formation at the wound site. Now, all these complications were associated with complex fractures. Now, we did a Cox proportion hazard regression analysis, where we found out what was the factor that was associated with poor visual outcome and with unfavorable cosmesis, and we found out that age less than 40 years and duration of trauma to reconstruction was the statistically significant contributors to poor visual outcome, whether factors like age more than 40 years, complex fractures and associated ocular injuries were associated with the unfavorable cosmesis. Now, this is when we did an ROC curve, we found out that any reconstruction done within 6 weeks had a better outcome, but in case if there is a multiple injuries, even a reconstruction done within 14 weeks had also a favorable outcome. So our study was comparable to other studies, but the differences were that 7 patients had undergone surgery at a general hospital where the orbitofascial component was not addressed, and that reconstruction was again has to be done in 5 of these patients. And all these 5 patients of 7 patients had a very favorable outcome. The average duration of hospital stay was only 2 days, and the median follow-up period was 5 months. So the limitations of the study are its retrospective nature and lack of uniformity in documentation of the size of the orbital fractures and the degree of inophthalmos. And then there was definitely an element of bias as the surgeons were assessing the cosmetic outcome. So we planned further to do an inter-observer tally of the cosmetic outcome. So I would conclude that for any sort of orbitofacial trauma, it should be managed in a coordinated way involving an entire team of maxillofacial surgeon, orbital surgeons, and vitreoretinal surgeons in the one roof and one setting, because this reduces the number of hospital admissions and visits and also gives a psychological and economical advantage to the patient. Thank you.
So thank you for your wonderful talk. So, is there any question from the floor? Oh, no. Okay. So, this great talk, and I have one question. So, what factor contributed to the delay in presentation and intervention among the patient with oculofacial trauma?
Yeah, so because ours was a standalone eye hospital, so most of the patient with trauma do have multiple injuries of the, let's say, systemic involvement. And unless the general condition of the patient is stabilized, they never come for seeking a complaint or the treatment for an ocular complaint like inophthalmos or decreased vision or diplopia. That was the main reason why there was a delay in presentation to our hospital.
So, can you find out the cause for the poor cosmetic outcome in 22% of the patients?
Yes, in most of the patients who had come to us is basically when we had a very large or a very complex fracture. Definitely at presentation the facial asymmetry was very bad. So whatever we did in that reconstruction, definitely there was an improvement, a visible improvement in the cosmesis, and that led to a favorable outcome. But if there is a simpler fracture, the cosmetic appeal was not that much disturbed. So even if you do a good surgery, so the patient did not find, or the surgeon did not find a significant improvement in the cosmetic part of, but the visual acuity was always recorded, and we have a subjective assessment or an let's say an objective assessment or a grading system for the vision. But for cosmesis, what we did was what an observation or the degree of inophthalmos. So that's what the dilemma and the limitation of this study.
Any recommendations?
So here, what we suggest that next when we go for a similar kind of study or to extend the study, we can always do a inter-observer comparison of the cosmetic outcome. Like we have planned for a study where the photographs of the patient will be graded as per the cosmetic symmetry or the facial symmetry. One seen by the patient itself, he grades his cosmetic outcome. Then the surgeon itself who has done the cosmetic outcome. And then an independent observer who is not at all a professional will see a photograph and see what is the cosmetic symmetry, and then that would more validate this results.
So thank you so much for your presentation. So Dr. Bashins will introduce next two speaker, and so next speaker.
I will call upon Dr. Trong Dang Min Pham for his presentation on clinical case report, total cyclodialysis after blood trauma. Your time starts now.
Good morning, everyone. My name is Phạm Trường Đăng Minh, and I'm a resident from Vietnam. And this is a case report of a total cyclodialysis following a blunt trauma. And cyclodialysis is a rare entity that following the blunt trauma that could cause many problems in managing and observation for the patient. I have no conflict of interest to disclose. It appears a 22-year-old male patient with chief complaint of blurred vision in his right eye. He has a history of blunt trauma from a badminton shuttlecock 4 months ago with no prior treatment. He has no significant family history. Upon examination, we found his BCVA was just counting finger at 5 meters, and IOP was reduced at the point of 4.4 millimeter mercury. He has shallow anterior chamber, and he shows signs of cyclodialysis cleft from the position of 7 o'clock to 12 o'clock upon gonioscopy. And when we did a fundoscopy for him, we found the signs of vascular tortuosity, optic disc edema, and chorioretinal folds. Due to these complications and the history of blunt trauma, we can see that there's a cyclodialysis cleft for the patient. Therefore, we initiated an UBM, which we found a very interesting symptom and signs that we found there's a cleft extending for a 360-degree form in every corner of his eye, associated with a suprachoroidal fluid in every position, as we can see in these on the screen. Therefore, diagnosis at this point was total cyclodialysis with a complication of hypotonic maculopathy secondary to blunt trauma. And let's review a little bit about the treatment option that we have at the current moment. Many contemporary authors agree that we should put the patient on atropine, and first in the first 8 weeks, and if after the 8 weeks the patient still experience the symptom and signs of hypotonic maculopathy, we will persist with more invasive treatment, ranging from phaco, vitrectomy, laser, and cyclopexy. However, this is where the current order differ, because there's no consensus reached regarding the surgical treatment and laser treatment when it comes to the cyclodialysis. When it comes to our patient, we also initiate the atropine 1% for the patient, and after 8 weeks, we found that there's a reduction of the fluid, suprachoroidal fluid, and a reduction of the size of the cleft from the position of 1 o'clock to the 6 o'clock. However, the picture from the 7 o'clock to the 12 o'clock remain the same. Therefore, this is the position that we'd like to further the treatment for the patient in this position with more invasive treatment. And due to those and because we have many options at the moment, therefore we'd like for the patient to have a chance to experience and undergo a less invasive treatment first before furthering him with phaco or vitrectomy. And therefore, in the position of the 7 o'clock to the 12 o'clock, we perform a scleral cryotherapy in this position. And fortunately, 4 weeks after the procedure, we found that his BCVA reached 20/20, and his IOP was normalized. We found no IOP spike in our patient, and the fundoscopy was also normalized, and gonioscopy and UBM, we found no observed cyclodialysis cleft anymore. And upon the UBM, we can see that the UBM was normalized with no evidence of suprachoroidal fluid anymore and no cleft presenting. And let's have another slide to compare the picture of the patient before and after the treatment with atropine and only less invasive treatment called transscleral cryotherapy. And we can see that the suprachoroidal fluid has been reduced to that leave no trace of the fluid under the sclera of the patient. And we can also see that upon the fundoscopy, we found no signs of hypotonic maculopathy anymore. Therefore, through this case, we'd like to propose that clinical examination and UBM could establish a diagnosis of the cyclodialysis cleft, present, position, and extent. And we'd like to propose that the conservative treatment should be first considered prior to more invasive approaches. This is my references, and thank you for your attention.
It seems like every meeting I go to, it seems like I see another shuttlecock injury. So the question is, are you supposed to be wearing eye protection when you play badminton? I don't know.
Sorry, come again.
Are you supposed to be wearing eye protection when you play badminton?
Yes, I think that we should wear protection when we play badminton. But unfortunately for the patient, he did not wear any protection, and that's not a common norm for the people, at least in my country, to wear protection
It is.
when
So
he play. Yeah.
in general, people do not
No,
wear
no, they do not.
because it seems like, I mean, I see this, I hear about this injury
Okay.
quite often. I don't want to say quite often, but it seems like every meeting that I go to, someone's showing another shuttlecock injury.
Okay.
And
Yes,
so I'm
that's
just
right.
wondering if we should make a recommendation as ophthalmologists that, you know, when you play badminton, you should be wearing eye protection.
That's true, and I totally agree with you. But unfortunately, it's not a common, it's not a norm here.
Yeah, please.
My friend knows I'm on either sides as a player as well as an eye surgeon, so I can tell you something about it. It's very cumbersome to wear spectacle or protection during a play, so that's not an easier thing. But yes, of course. I also suggested BWF, which is Badminton World Federation, after our bidirectional cohort of retrospective cases and player and coach level intent to adapt to practices that can prevent eye injuries. So the work is almost done, and will shortly be publishing also in the Journal of Racket Sciences. So yeah.
Great.
Great.
Thank you.
Was there any associated trauma to the associated structures of the eye, like zonular dialysis, or because angle
rather-
damage? Because to have a cyclodialysis cleft all 360 degrees.
Rather than cyclodialysis with a complication of hypotonic maculopathy, the patient showed no more signs of any further complication. And that's also why we chose the cryotherapy. So that's for the patient to have the chance to experience the therapy that is less invasive first. And some other even propose that we should do a vitrectomy for the patient because the extent of the cyclodialysis cleft was so large that is standing for a 360 degree. But after only less invasive, like in our case, we can see that the remission was really good, and the prognosis is also really good.
Good. But we should follow these patients for long term because they can develop other retinal pathology or complications due to the trauma which has occurred.
Yes, that's true. We found no the complication. We found no other complication in his corneoscopy. We found no signs of high IOP, no sign of glaucoma. But we will definitely follow him up for a long term.
Thank you.
Thank you.
Any other question from the floor? Can I call next person? Thank you. Our next speaker is Dr. Wenwen Yang. Yeah, Wenwen Yang. Is he present? Then Kevin Setiawan.
Kevin is here.
Kevin has uploaded. Should we allow?
So,
Let
Kevin
us.
Chung is here.
No, they have uploaded their video here.
Yeah, right. So
We can do it at the end.
Yeah, at
Even
the end of
this-
the session, we called their name.
Yeah. Kelvin Cam, you're here. So he will be speaking on inhibition of interleukin 6 receptor IL-6R signaling with satralizumab in thyroid eye disease.
Thank you very much for the opportunity to speak on behalf of the study group. I'm Calvin Chong from Hong Kong. These are our financial disclosures. There is currently an unmet need for thyroid eye disease, as you all know that this is a complex autoimmune disease, and current treatment in terms of both intravenous steroid or the recently approved IGF-1 receptor inhibitions actually has some of their drawbacks. In particular, these were more informations or data on active thyroid eye disease, but not on the chronic form. So there is, in fact, an unmet need for faster and durable systemic treatment with fewer or more acceptable side effect profiles. In fact, when we look at various pathway, interleukin-6 as well as its receptor play a key role in the pathogenesis of thyroid eye disease that is evidenced and published in both in vitro tissues, cellular models, as well as some clinical evidence in clinical trials using other interleukin-6 biologics. Satralizumab, on the other hand, is a humanized monoclonal antibody that targets also the interleukin-6 receptor pathway. If I have time, I'll elaborate on this, but it's designed with a novel antibody recycling technology, so much so that this is usable in a subcutaneous form of injection and is now tested in every 4 weekly injections. It also binds all forms of interleukin-6 and its receptors, and it has very, very good side effect profiles, as it is already in use in another form of autoimmune disease, NMOSD, which is a neurological neuro-ophthalmic conditions, and over 4,000 patients have been treated so far with very reasonable safety profile. So the drug itself, satralizumab, is designed to enable maximum suppression of the interleukin-6 pathway, as well as allowing very practical dosing because of a subcutaneous form of injection for patients. These is the study design. SatraGo-1 and SatraGo-2 actually are two identical global phase 3 studies. And because of the widespread use of the drug, phase 1 and phase 2 studies is not necessary. And these were the list of the countries that were involved, and over 140 study sites and around 120 study patients has been included. These were the standard key inclusion and exclusion criteria. These two studies actually target two types of thyroid eye disease, both moderate to severe, active, as well as chronic inactive thyroid eye disease. Okay. And this is the dosing flow chart. I want to draw your attention. Unlike other biologics that has been tested, for patients who are not responding in terms of the primary outcome for proptosis reduction at week 24, they're being re-randomized. For those patients who are not responding to the drug, whether they were randomized to placebo or not, they will be given an open label form of the study to receive the drug, to see if after 24 weeks of either form of treatment, either group of treatment, a delayed treatment, whether it will work. For those who respond, they will be randomized again into 1-to-1 ratio to either receive the drug for another 24 weeks or to placebo. So there are a few things. I understand the study design is a bit complicated. That's why I spent a bit of time, is to see that whether the primary outcome is the proportion of active thyroid eye disease patients who respond with the classic 2 mm or more proptosis reduction from baseline at week 24. But there are various secondary endpoints. I think that makes sense too. It's proportion of patients with more than 1 grade of improvement in diplopia. For those who have not responded in the first 24 weeks, if they are randomized to treatment, whether they would also respond if we give the drugs for another 24 weeks. For those patients who are randomized to placebo and not responding, they will be given the drug for sure. So we'll see a delayed form of treatment, whether it will also work. Of course, we will also be looking at the incidence, seriousness, and severity of adverse event. So in summary, this is mainly the study is still ongoing worldwide, and Hong Kong is one of the study sites, and I'm representing the study group. So in conclusion, SatraGo-1 and 2 will become the largest randomized controlled trial as of today for thyroid eye disease. We'll have more than 240 patients on the two parallel studies, looking at the use of this interleukin-6, different from the current form of tocilizumab, to look at both active and chronic thyroid eye disease. Thank you very much.
So is it the half-life that differentiates it from tocilizumab?
Yes, exactly. Because of the technology, I kind of understand it is a recycling technology because of the pH dependent. Usually, the antibody will go into the cells, goes to something called endosomes, and because the technology of this drug, it recycle itself better in the forms of keeping the drug in the system longer. So you can do two things. You can have, instead of week 3 dosing, you can have week 4, number 1, number 2. Instead of intravenous dosing, you can have subcutaneous form of dosing. And we are testing this in subcutaneous form. So I think this is something that is different from the current use of tocilizumab or the other form of interleukin-6 biologics. The second thing that makes it different is because it blocks all types of interleukin-6, both membrane form and soluble form, unlike the other interleukin-6 biologics.
So, Calvin, wonderful talk. I have a simple question. So, how about the effect between inactive patient and active disease patients? So, how about the comparison between two of them?
In fact, this is not shown in here. The ratio between active and inactive patient will be 3:1. So they want to check a number of hypotheses, and they're very ambitious, I would say, because they want to do a large study at the same time runs over that 48 weeks period. So they were looking at the response for both active patients and inactive patients, but mostly for active patients because for approval purpose. I'm sure you understand the point. And they do not want to spend another years to test it on chronic patients, but they do want to see if chronic patients would respond. So that's why the ratio will be 3:1.
Yeah, the whole use of monoclonal antibodies targeted therapy in chronic disease is very interesting because, I mean, from my standpoint, this is my opinion, purely my opinion. I don't want to get in trouble, but for me, I have very effective treatment for chronic thyroid eye disease that has probably very few side effects. It's not nearly as expensive, and it has a durable result. And that is surgery.
I understand.
Yeah, I mean, it's just the teprotumumab reps in the U.S. really try to push teprotumumab for chronic disease, and I always come back and I say, why would I ever do that? I have this relatively inexpensive, durable, not a lot of side effects, and I think it's an interesting argument.
I agree with Richard, because for colleagues who let me put it this way, for colleagues who prefer surgery, they would not be interested in chronic form of the disease. We understand that for active form of the disease, most of the time, unless it's visual threatening, we will wait. But I also understand that it's not just a surgeon problem. It could be, since the patient has already been with the disease for 5 years. For this study, it's up to 10 years. They would probably consider non-surgical treatment if this is proven with reasonable, not better, reasonable or comparable efficiency. I kind of understand the rationale, because if we see chronic thyroid eye disease patients that lives with the disease, of course, we can show them that we have perfect surgical results with minimal side effect, very low incidence of side effect, but they already live with the disease for such an extended period. If there is some form of subcutaneous injection that may help a little bit, I understand.
No, I do. I agree.
Thank you.
Is there a question from the floor? Okay, let's move to the next topic.
Okay, we're going to have our own Dr. Shin discuss topography of corrugator supercilii muscle relative to the eyebrow and its clinical application with botulinum toxin injection.
Okay, so I'm gonna move to the. There's no present. Oh, okay. Do you have a pointer? So Could you give me a slide? Okay, so my name is Jim from Seoul, South Korea. My topic of presentation is topography of the corrugator superciliary muscle relative to eyebrow. So, as you know, corrugator muscle, abnormal contraction, involuntary contraction of corrugator muscle is very important for pathophysiology of blepharospasm. So, blepharospasm, the treatment choice is botulinum toxin. So we're gonna inject botulinum toxin, so our corrugator muscle, orbital ocular muscle like that. So in this regard, topographical knowledge, anatomical knowledge of a corrugator muscle is very important for precisely administration of botulinum toxin for your corrugator, orbital ocular muscle like that. Actually, in the real world, most of the clinicians rely on the position of eyebrow to guide the botulinum toxin injection rather than bony landmark. However, the problem is that there is a lack of information on the position of the corrugator muscle relative to eyebrow. Maybe you can see that the injection of a botulinum toxin injection site markedly different in each image. In this site, so injection site is above the eyebrow, and this is inside of the eyebrow. So there is no standard injection site, and every image differently describe the injection point. So therefore, in this present study, we're gonna elucidate the topographic relationship between corrugator muscle and eyebrow position for guiding precise botulinum toxin injection into the corrugator muscle. Here is the method. We dissected 33 hemifaces, 18 Korean cadaver, and so we gonna use this landmark A1, A2. This is the medial end of the eyebrow, upper point and low point, and B1, B2. This is upper point and low point of the middle pupillary line of the eyebrow. And then we measure this 6 distance from the facial midline and interconstant line. So after exposing so orbicularis ocular muscle, this is orbicularis muscle, and this is the corrugator muscle. We marked again the 4 landmark of the eyebrow on the corrugator muscle. So this black dot demarcated corrugator muscle. These 4 blue dot is an eyebrow landmark. And then so we superimpose each image on the top of an already existing image with a reference line like this. We superimpose each image like this. Okay. Let me tell you the result. The measured distance are detailed on the table, and there is no any other sex difference related this measurement. This is the blue dot is the eyebrow position, and red dot is a corrugator muscle. And so this image, this blue shadow is an overlapped eyebrow. This red shadow is overlapped corrugator muscle. And you can find that corrugator muscle originated inward than medial end of the eyebrow, and then so eyebrow and corrugator muscle overlap in the medial end side. However, it extend outward. The muscle, corrugator muscle, gradually raise above the eyebrow like this. So green dot is dot in the middle of the corrugator muscle. So this is the ideal line to injection botulinum toxin into the corrugator muscle. So what I want to talk about that, so you know, difference between Caucasian and East Asian. So usually this is the book for you know, Caucasian injection site in botulinum toxin. Maybe you could find that the injection site is described above the eyebrow level, because you know, Caucasian eyebrow is a position more lower than East Asian. So, but I want to point out this position. So because East Asian eyebrow position is much higher than Caucasian anatomy, so because of the injection, eye injection point is within the eyebrow, not above the eyebrow. So, and in summary, so because of the racial differences anatomy, the botulinum toxin injection site for effectively treating blepharospasm is medial, and especially the medial part is within the eyebrow, not above the eyebrow. So that's my point. Thank you for your attention.
Did you see any differences between gender, male and female, or did you have enough data
Yeah,
to look at that?
that's great questions, Alan. There is no sex differences, but I cannot confirm age differences because most of the cadaver is 78 years old, and I cannot get the young cadaver. So you're right. Yeah, that's the main limitation of the cadaveric study. We can only get a elderly patient cadaver. Yeah, so right. So
Yeah.
the background of the study is that, interestingly, some of my patients living in the U.S., even though they are Korean, so they come to me, get a botulinum toxin injection for blepharospasm twice a year, long flight. They told me, "Hey doctor, so I inject botulinum toxins in USA, but the impact is not same as I get the injection in Korea." So I very, got interested about what's the anatomical differences between Caucasian and East Asian populations. So clinicians usually we rely on the eyebrow position. So notice that there is some corrugator muscle anatomy difference between Caucasian and East Asian.
All right, thank you so much. Any questions from the audience?
Thank you.
Great, thank you. Okay, our next speaker will be Dr. Yulhak, elucidating the pathogenesis of retinopathy in a zebrafish model of carnitine palmitotransferase 1 deficiency. If they're here, they may not be here. So we're going to move on to Dr. Zhang, the effective knockout of non-coding RNA in MIR183 cluster on retinal structure and function and its mechanism. Maybe another one that's not here.
Yeah, yes. Our last speaker is Leona.
Okay, we're going to go with Dr. Ponier. Patient-specific perceptual visual stimulation improves vision and contrast sensitivity in cross-linked stable keratoconus, results of randomized control study.
Thank you so much, dear chairpersons and my dear friends. Good afternoon. The topic for today is visual cortex training using Gabor patches that would improve vision and contrast sensitivity in cross-linked stable keratoconus, results of a randomized control study. I'm using a product from Israel as visual cortical training device, but I don't have any financial interest relevant to it. The CLEC study and various other publications on keratoconus exhibited, they showed keratoconus is a progressive ectatic condition where there is decreased best corrected vision and low contrast acuity, and this is deteriorating more rapidly than higher level of contrast. And even keratoconus subjects with good visual acuity, despite having good visual acuity, had reduced contrast sensitivity and increased higher order aberrations compared to controls because of the irregular astigmatism and irregularity with the refraction that happens in the anterior cornea and anterior surface of the eye. The reduced quality of vision also causes dissatisfaction and experienced as halos, starburst and glares, just like multifocal lenses, and reduced contrast vision. On the other hand, while cross-linking in keratoconus stops progression of the disease, they do not typically restore vision which is lost, and patients are left with poor best corrected vision. Parallelly,
perceptual learning therapy to stimulate the visual pathways and the cortex using Gabo patches significantly improved vision in childhood amblyopias, in adult amblyopias, and in certain conditions like macular diseases like Stargardt's disease, nystagmus, all those reports are available. So we justified and attempted to use this perceptual learning therapy in improving vision in patients with stable keratoconus post cross-linking.
Yes.
So the research question is, when vision is limited to both capturing and processing in the brain, why do we only treat refraction? So we thought, and we started to work on improving the cortical connections. So the primary objective is to evaluate the efficacy of cortical stimulation web-based app regime using Gabo patches to improve vision and contrast sensitivity in patients with stable keratoconus post cross-linking. And the secondary outcome measures were to understand the percentage of subjects that improve best corrected vision by 2 or more logMAR lines over the baseline, or patients who improve contrast sensitivity function by at least 50% over baseline at the end of the therapy and 6 months following therapy. It's a phase 3 open label prospective randomized control study. 20 to 55 years old stable keratoconus post cross-linking over a period of 1 year were randomized. 45 subjects randomized in 2:1 ratio, 2 into the treatment group and 1 in controls. So there were 40 home training sessions during 12 weeks, 3 months, and a mid follow-up after 20 sessions, and end of follow-up by 40 sessions, and post-treatment 6 months follow-up was observed. Vision in ATDRS characters, contrast sensitivity using FACT were analyzed. So yeah, 30 randomized in treatment arm and 15 in the control arm. Both the groups were examined by ophthalmologist and optometrist, blinded to allocation and screening conclusion, and after 6 months. So 42 subjects completed the study. There were 2 follow-up loss in the treatment group and 1 in the control group. The baseline characteristics were comparable between either of the groups, and the subjects were allocated based on the random table distribution. And this is a Gabo patch, gray level gratings you can see, and Gabo patches are designed to match the shape of the neurons receptive fields in the primary visual cortex. So they tend to overcome the plasticity of the connections at the neuronal level rather than in the refractive plane. And it's interesting to see when a target is just used, a Gabo patch, the neuronal response was significant, and when only flankers, collinear flankers were used, the neuronal stimulation was less. When a Gabo patch was used along with collinear flankers, the response was most. So this concept we utilized in this particular web-based regimen. So the compliance was monitored well, controlled home environment, 30-minute sessions, and data was sent to the data center, individual sessions based on patient's need and the progress. So these are various types of stimulus that we used based on spatial frequencies, local orientations, contrast, global orientation, target and the flanker separations, and displacement either on the right or left. The results, there were 2.5 logMAR lines improvement in the vision in the treatment arm from the baseline over a period of time by 40 sessions, and the improved vision also remained stable after 6 months during the follow-up, whereas there were no significant improvements in the control group. This is a representative case example. One of the patient, you can see by the baseline of 0.56 logmar was the vision, and after 40 sessions improved up to 0.04. And similarly, another case, you can see the improvement over time. The changes in contrast sensitivity, the Friedman test for repeated measures showed no statistical difference amongst the controls, whereas there was significant improvement in the treatment arm at all spatial frequencies, and this proves the patient's contrast sensitivity improves. And the individual spatial frequencies at 3 cycles, 6, 12 and 18 cycles per degree using repeat measure ANOVA, we found significant difference, and we also found at higher spatial frequencies more than 50% improvement in contrast sensitivity from the baseline was observed, and which is well maintained after therapy. So what was known very well, keratoconus causes irregular astigmatism resulting in reduced best corrected vision, contrast and quality of life, and cross-linking stabilizes the disease but not improve vision and contrast sensitivity functions. So what the paper adds, quality of vision is a product of good image capturing and processing. While all modalities only treat refraction, that is image capturing, visual perceptual learning therapy is a promising complementary measure to enhance image processing in cases with stable keratoconus, and this acts as proof of concept that the therapy works at the cortical levels, improving synaptic and postsynaptic interfaces. So we recommend that anterior segment surgeons could consider this adjuvant as a better supportive treatment for cross-linked keratoconus with visual deficiencies. To conclude, sequential patient-specific perceptual learning programs improved vision and contrast sensitivity in cross-linked keratoconus with visual deficiencies and acted as proof of concept for establishing neural connections at cortical level. Keratorefractive surgeons could consider this promising no side effect tool, just an ocular physiotherapy, as a post-operative therapeutic adjuvant as a comprehensive concept. So the key to optimizing vision is not alone in the spectacle plane or in the corneal plane, it's also beyond at the brain level. Thank you so much for your listening.
Is there any question from the floor? It's very interesting randomized study. So I have a quick question. So you are in your protocol, so you train each patient 30 minutes. So each patient trains 30 minutes, right?
30 minutes,
Yeah,
30 minutes,
yeah.
3 times a week.
Yeah.
For a period of 3 months.
3 months, right? If the patient the training more than 30 minutes, like 1 hour, 2 hour, do you think the effect of the training is get enhanced, or it does not correlate with the time and interval in frequency?
Interesting question. It's like a golden geese should training more than 30 minutes. Does a geese produce more golden eggs? Something like that. The protocol is designed in this way because in childhood amblyopias and for adult amblyopias, the manufacturer is already using such regimen. So the same was adopted. But yeah, we can work on future studies to understand if excessive training, does it give excessive result beyond this.
Do you think the result is durable, or would they have to do the training again maybe every year, or
that's what
it's long-lasting?
We saw all these cases after 6 months of training. After 40 sessions, no more training were given, and by 6 months we observed there is stability, but obviously yes, we need to know if there is decline over a period of time. So longitudinal analysis we are interested in
Yeah.
having the patients on.
So you think so? Could we apply this Gable patch training into other brain diseases like homonymous hemianopsia after brain lesions or other the brain problem patient, neuro patient?
Well, they are not field expanders to expand the visual field, but they can improve contrast and quality of vision. Let's assume this way. A central scotoma due to macular disease, acquired macular disease, such things are being tried, and there are good case reports on it, case series on it, that patients have improved vision, they passed the license test to drive, all those. So maybe yes, we can, yeah. So the indication may extend beyond.
Thank you so much for your great
Thank you.
talk. So if there is any question from the audience, we're gonna wrap up this session so earlier. And so thank you so much for joining us today, this last session, the last day. And any comment?
No, thanks. No, really appreciate everybody staying.
Yeah, thank you. And so all the speaker, please, let's take a group photo. Yeah, right. Even though it was Wednesday. Yeah, right. Just for the memory.
Absolutely.
So, could you please take a group photos?